All right.
Hello. Hi, everyone.
Yep. Hello, everyone. Thanks for joining us again. Dr. Tom Nabedy.
Dr. John Santa Ana.
We're at Michigan Center of Regenerative Medicine, and tonight's topic is to discuss the benefits of utilizing musculoskeletal ultrasound, both diagnostically as well as interventionally.
Correct. Yeah.
So I guess just kind of jumping right into the benefits of a musculoskeletal ultrasound. It's a device that is mobile, so it can be moved from room to room. And in my opinion, it's something that's really improved my diagnostic skills in the exam room. So in doing a evaluation of someone's shoulder, knee, hip, having a musculoskeletal ultrasound that can actually look through the skin, it's been a huge benefit to my diagnostic skills as a physician.
Yeah, and I think one of the biggest advantage of the musculoskeletal ultrasound machine in general is because it uses sound waves to look at structures. It's portable enough that we can have it here in the office. And unlike things like X-rays, CAT scans, and MRIs, there are no health contraindications to it because there's no radiation. It's really easy to use. It's very benign. And definitely gives us a really good insight on what's going on with patients.
I think one of the great examples of that is, pregnancy. It's the diagnostic imaging modality of choice because there is really no injury that can be done to the patient or to the baby.
Yep. And then the nice thing about the ultrasound too is that unlike X-rays and CAT scans and MRIs, we have the ability, because we can't keep it on the whole time, we can take static, still images, and then you can also use dynamic images. So we can actually watch the joints and the structures move and how it all relates to mechanics as far as what gets caught or what's getting impinged whenever we use it.
So I think it's a really great point. I mean, probably one of the most important factors of using ultrasound is that it's a dynamic imaging modality. It's one of the only dynamic imaging modalities. So let's give some real examples of why that would help. Let's say you're coming in and you got a shoulder issue, and doing your exam and coming up with possible reasons why your shoulder is hurting. It's awfully nice to be able to see on exam. Let's say you have an impingement sign where when you lift your arm, it looks like your rotator cuff tendon is being pinched between two bones. Well, with an ultrasound, rather than writing an MRI order and having you go to get an MRI and a couple of weeks later come back and we look at the image and it's a static image and you look for maybe some damage that's being done to the rotator cuff. What about putting a probe on you right here and now and then have you lift your arm up and let me see if that rotator cuff's being pinched by the bone. So it's a clinical tool that you can use point of care to get immediate feedback while you're evaluating the patient on the day that they came into your office. It really helps expedite your decision-making process and then coming up with whatever treatment plan you think is best for your patient.
Yeah, and I think one of the nice things that you and I like to do whenever we talk to patients is trying to explain exactly what's going on. So everyone's on the same page as far as what the diagnosis is, what we're trying to treat, what structure we're trying to do. So it becomes a very educational thing for me and the patient whenever I go through this consultation. So with the ultrasound, typically when you see a report, you see, there's a partial tear or mild degree of osteoarthritis or something like that. I think being able to visualize exactly what does that mean? What does a partial tear in your rotator cuff tendon mean versus a full tear versus what's a mild arthritis versus a moderate or a severe. So, it kind of gives you like that added depth of information as far as you really do understand what's going on. So when you do make these important medical decisions, in the case of regenerative medicine, these very important investments on your health, that you know exactly what's going on and everything's pretty transparent.
Yep. And it helps with the severity of disease. There's always a spectrum when something's sprained or torn, partial tears, complete tears.
The next step with the diagnostic, being a diagnostic tool, is it being a tool for treatment, right? So when we say that, we use the ultrasound when we do our joint injections and other injections to guide our treatment. So knowing exactly what structures to treat and where is that exact tear and where the problem is, then we can target that area specifically. So patients can actually, some patients do enjoy it. They actually watch the needle enter, go to the structure, get into the defect, and then you can actually see the medicine or PRP or stem cells kind of get into those areas to try and fix it.
Yeah, it is my interventional modality of choice. If there's an option between ultrasound or X-ray, and I can equally see the targets, I always prefer ultrasound because you get that dynamic flow. You see the medicine flowing directly into your target. You know that you either got a great spread of the medication or the regenerative substance, the PRP or the stem cell, right under your target, or if it's not flowing in there, you don't just keep injecting. You reposition your needle so that you know 100% of the time, every time you do a procedure, you delivered the product where it needed to go.
Yeah, and it's actually really nice to see compared to the X-ray when we use for spinal procedures. We use the X-ray. One of the nice things about the ultrasounds, like you mentioned, is you get to see the soft tissue and vessels too. So as far as from a safety point of view, you see vessels, you see nerves, you see soft tissue, you see bone. The only biggest downside with the ultrasound is that you can't see the deep structures. You can see most of the superficial structures, which in joints should work pretty well. But when we need to do more deeper things, then we have the fluoroscopy for that.
Yep. So kind of it's a jack of all trades, so to speak, diagnostic tool. It really sees a spectrum of conditions. It can see things in static imaging or as you're moving in dynamic imaging. Certain things are necessary. Certainly, I'm not saying an MRI is not necessary. There's certainly reasons why you would still need to get an MRI. The quality of those deeper structures from a diagnostic standpoint, but from a point of care, meaning what we can do in the room with you while we have you there, it's been an extremely valuable tool of mine that I didn't get trained on during my residency. It wasn't anything that was part of our training program. These are things that we picked up and continued to learn as science evolves and medicine evolves. You can't just stick with what you're taught during those 4 to 5 years of residency. You got to continue to move with the science and move with medicine. And I think that's probably two of the stronger qualities that Dr. Santana and myself possess, is that we're always looking to continue to improve upon what we can offer our patients by continuing to do medical education and going out and getting additional certifications and training programs.
Yeah. And then, like with any other, with this, especially with ultrasound, I think more than any other imaging modality, it's because it's very centered on kind of how proficient the physician is, that it's all repetition. So it's, you don't become proficient with just doing one course or looking at 2 structures. It's saying the same things over and over again. Then you start to see all these anomalies and abnormalities
and correlating upon different modalities. Like a lot of times we'll pull an MRI up. We'll be looking at the MRI on our computer while we're looking at the structure with ultrasound. I'll pull John in, John will pull me in. We'll look at things together while we're here in the office. It is
nice luck.
It's a great, and it's been just a tremendous learning curve for us. And now we've gotten quite proficient in knowing what we're looking at and being able to confidently identify abnormalities when we're finding them.
Yeah.
So maybe a good time to pull you into the procedure room here. We're going to demonstrate how a musculoskeletal ultrasound works, and we would invite anybody that has questions at this point. If you wanted to start asking us any questions, we'll try to answer questions as we're doing, as we're kind of intermixing with the demonstration. All right.
Okay.
Just a second. We'll get you in the OR. All right. Hi, everyone. We're back here. As you can see, we have our ultrasound machine. Dr. Santana has volunteered his knee. And this is the ultrasound probe. So a couple different probes, depending on what structures you're looking at. There is what's called a curvilinear probe, which is more designed for deeper structures, lower frequencies on the ultrasound imaging, and then the linear array probe, more for superficial structures. So for today, we're going to look at Dr. Santana's knee. So I'm going to use a linear array probe. And you can see up here with the ultrasound machine, as I tap, you can see which side of the probe is aligning. So the first structure I was going to look at for his knee is his medial femoral condyle. So as we're coming down here, here is his femur. Bone shows up bright white on an ultrasound machine. and then the end of his femur is right here. And fortunately, Dr. Santana still has a good amount of cartilage. So one of the benefits to ultrasound is that you can see soft tissues. Unlike x-rays, if we were to take an x-ray of his knee, we would see the space between the two bones in his lower leg, and we could assume that it was cartilage that was separating those two bones. And one of the things oftentimes we get is patients who have been evaluated for knee arthritis, and they're told they're bone on bone. The native cartilage cells to make more cartilage. So if you don't have any cartilage cells to begin with, you're not a very good candidate. Now we have some different techniques with doing intraosseous, which is probably beyond the scope of what we're trying to talk about today. If you're that severe, we still potentially have an option for you. But long story short, this ultrasound and being able to see whether you have a good amount of cartilage left or not is an important part of our diagnostic ultrasound of the knee.
So in combination with, getting a good MRI, getting a good X-ray, a good physical examination, and the ultrasound, it just gives us all of these tools and pieces of information to come up with the right treatment and diagnosis for it.
Another common area of the knee that we'll oftentimes want to look at is the meniscus. So meniscus tears are a common injury, both acute for people who are involved in like athletic injuries, as well as degenerative over time. And when we're looking at the, getting back on center here. So we're looking at the meniscus here. So you look at his femur here, his tibia here, and our meniscus cartilage is a triangle cartilage in between. Again, doesn't look like Dr. Santana has any meniscal damage. Things we look for are meniscus extrusions, and on the top of that is his medial collateral ligament. So when you see the meniscus starting to push upwards and extrude out, it tells you that it's becoming lax. The medial collateral ligament is becoming lax, and the meniscus is actually moving out, which can lead to pain and eventually degeneration, if not tearing already. Other structures we can see really well on the ultrasound are things like the patella tendon here. Patella tendon inserts. This is on his lower leg. Again, bright white structures are bone. These fibular-looking wider structures there is the tendon. People who have chronic tendonitis, that tendon will thicken. People who have things like Osgood-Schlatter disease will have and develop these osteophytes, these calcifications, these bony overgrowths into the tendon, things that we can easily see. Very similar on the quadriceps tendon in the top half of the patella. So here's our patella, here's our kneecap there, and then we can see our quadriceps tendon coming in and inserting there. Looking for tendonitis, quadriceps tendonitis. You can see again, hypertrophy or the enlargement of the tendon. You can start to see little gaps in the tendon. And then if we look at a vascular flow pattern, oftentimes you can see neovascularization in there as well. All things that give us information as to why your knee might hurt and what sorts of treatments might be available to improve.
And one of the way that I use this view too is if you have any type of swelling or buildup of fluid inside your knee, usually you would see it coming out from underneath your kneecap in between your femur. You get like a bubble of fluid in there, so that kind of indicates and tells me that there's something going on inside the knee, whether it's arthritis or a meniscus tear or something along those lines.
And then if we are to, let's say he would have fluid in the knee, maybe there was a pocket of fluid to drain, you can see with the ultrasound and coming in from the side, if our target is right here, you can see your needle coming in and it ends up creating a linear line without poking Dr. Santana. If we put that underneath the probe, you can kind of see it there. Yeah, it's probably not going to be the best demonstration, but you can see your needle tip as it penetrates, extrudes out through, and backside of the knee pain. It's a nice way to evaluate whether it's a fluid-filled sac that's causing it or not. So,
yep.
Dynamic type imaging for the knee. If you're looking for medial collateral ligament injuries, by actually giving, so if I take my hand and I I put a distracting force on his knee. I can see whether or not his knee up here is separating or not. That's a nice way to pick up on MCL sprains, ligament sprains. You can do that really with any joint in the knee. The most common is the MCL. So we have diagnostic structures we can look at, soft tissues that you can't see on x-ray, things like cartilage, things like ligaments, meniscus, tendons, not just looking for bony fractures or assuming what the cartilage is doing by seeing the joint space narrow. So it's got advantages to x-ray there. And then from a dynamic standpoint, you can put force, straining force on the knee to see if you see a movement in the bone that shouldn't be there or separation of ligaments that shouldn't be there. And then from an intervention standpoint, again, not a great demonstration of that today, but you can see the needle tip as it penetrates through the skin and make sure that it's directing and getting what either your medication or your orthobiologic directly into the structure that you're intending to hit. So you're 100% certain that you deliver the medicine where it comes to. And the reason that's so important for me is if we do an intervention and it doesn't end up helping somebody, there's three variables that I want to control for, and one of those variables is making sure I accurately deliver the substance to the target. And without ultrasound guidance, it's hard for me to 100% say I was accurate with my delivery.
Yep. And we've kind of heard this too from some patients too, when they do injections or they've come from other physicians who have had injections to the knee, and they come in and their knee's still swollen. And one of the comments I always hear is they tried to get fluid out of it, but they were not able to get any fluid out. But you can visibly see that the knee is still swollen. A lot of times, one of the things with the ultrasound is that we can find these pockets of fluid and actually target those directly. Number one, it makes it a little more accurate, so there's less pokes to do, and makes the procedure goes a lot more smoother and easier. So a lot of patients, they usually come to our office and say, like, wow, these injections are a lot easier, a lot smoother, and a lot less painful than some clinics have been to. And I think one of the reasons is, again, like proficiency with the ultrasound and the needle and getting into the right places at the right time easily and for the first time.
So we have a couple questions. I'll ask the first one here. It's from Dennis. He's asking, I have a shoulder problem, and my physician wants to get an MRI, but my insurance is denying. Could an ultrasound help? And that's
yeah. I think shoulder evaluation is perfect for ultrasound. Because we'll be able to kind of get to the right diagnosis a lot of times with this treatment. And if there's always a question, we can always try and push it through insurances with authorizations and stuff like that. So just because your insurance denies it the first time, if you really, really do need it, then we can justify it.
Yeah, and using the findings on an ultrasound, I've had success with in getting insurances to pay for MRIs when I feel like they're necessary, showing positive findings, negative findings. And that's one of the benefits to having this bedside as well. It's not a question we need to ask your insurance before we do the ultrasound exam on you. We just go ahead and do it. And, for the most part, I don't even know that we go for them, to be honest with you.
Yeah, a lot of times, like in every visit, if there's a structure, even if you bring an MRI or a CD or an X-ray or something like that, it'd still pull up the ultrasound anyway, just to kind of make sure that everyone's on the same page and knowing exactly what we're treating and what we're looking for. So every time we come in here, we're going to be pulling the ultrasound and looking at certain things.
So, got another question that came in about plantar fasciitis. Does ultrasound help for diagnosing plantar fasciitis?
Yeah. So one of the things that you kind of see with plantar fasciitis, when we do use the ultrasound, I think it's a really good tool for it, because you see not just the calcifications of the bone spurs that you see in the calcaneus, but you can actually even see the thickness of the plantar fascia. So usually with a fasciitis, you have inflammation of the tendon. And the nice thing about that is you can compare the tendon before treatment and then after healing and rehab and see how much of that tendon has decreased in size. So again, very minimally invasive. There's no radiation, very safe to use. You can use it pretty much the whole time without any consequence.
And kind of along those lines, the plantar fascia is very similar in structure to other tendons and that insert on bones. The lateral epicondylitis is another common one we get. Very helpful to use musculoskeletal ultrasound, because not only it helps for me when when trying to come up with a plan. If it's relatively early on, there might be indications for cortisone or for doing some physical therapy where we don't necessarily need to incorporate a regenerative treatment plan. Whereas if I start seeing tearing, I'm going to stay away from cortisone. I think that's where we get into trouble, and masking the pain as things start to tear, and really try to encourage patients to consider more of a regenerative route when I start seeing fibers that are tearing.
Yeah, and then for me too, just being able to image the structure that's the problem, it kind of helps me visualize how I'm going to approach the procedure too. So it's me kind of forward planning on how we're going to address and do this injection and formulate a treatment plan with it, just by being able to visualize that and kind of seeing the lay of the land before I go in there with a needle.
So we have another question coming across about multiple joint problems and having difficulty finding a diagnosis for multiple joint problems. I would say you're probably talking to the better two to try to dive into that. You know, we're not just a shoulder guy, we're not just a knee guy, we're not just a back guy. Our training in physiatry, physical medicine, and rehabilitation really looks at all structures, all joints, the body as a whole, and how mechanically it's connected together in exercise, supplements. And I think that's something that the two of us do pretty well. This guy in particular did a whole nother separate fellowship on functional medicine, and you know, the knowledge and the way that we've seen these things just fit together hand in glove really can help patients like yourself.
Yeah, so it all starts with a consultation and see one of us, and we'll be able to kind of take a deeper dive. One of the things that I'm proud of that we do here in the clinic is we really take stock in our patients and really take time to talk to them and really hear them out. The last thing that we want any of our patients to come through here and feel like they were rushed through the appointment. I want to make sure that they come through here and they know that we care and we're able to cover everything that they wanted us to cover.
Yep. I think that probably is a good point for us maybe to stop this. We like to keep these about 20 minutes. We're sitting at about 25 now. We appreciate everybody that tuned in. If we didn't get your question, we apologize. We'll try to reply via either email or messaging, however you want us to reach out to you. But appreciate everybody for tuning in, and we'll see you again.
Yep. And if you want to set up an appointment, just call 248-216-1008. We're in Rochester, Michigan. We'd love to talk to you. Thanks again.
All right. Thanks, everybody.